So this is very basic level, but it's good to become familiar with some of the process of doing a dental implant, especially for you guys in the front office, and then just kind of getting an idea of the parts, the pieces, everything that we use, and the process that we're going to go through to from kind of start to finish. So this is just like a brief overview, right? We take a tooth out, we put an implant in, we cover it, then we get a crown on it eventually, right? So that's kind of the basic idea of how we're replacing a missing tooth. So, when we first talk to someone about dental implants, people have a lot of things. They've heard things on TV. They've had their friend who had an implant. They know their Aunt Susie who had a bad experience, etc., etc. So when we talk dental implants, it's good to know a little bit of background, right? So the first dental implant was placed by Dr. Branamark back in 1965. So like 65 years we've been placing dental implants. And they've just been improving them all the time. Different surfaces, different thread patterns, everything working together to make a more successful product. So if you want something that's backed by years of research and everything, implants are one of those things. So the cool thing about implants, the reason that dental implants work is that they are biocompatible. Okay, what Dr. Branamark found out when he was doing research, that titanium actually makes a fusion to bone. There are these little proteins called hemidesmosomes that actually attach to the implant surface. So it's not like we're building like with wood, right? Wood, you put a screw in, there's a mechanical retention. Okay, it holds together, not because the wood fuses to the screw, but because the threads are bit into the wood, right? That's why screws are nicer than nails. It's because they bite into they bite into the wood. But the implants actually form a fusion with the bone, and that's why they're so successful. That's why we make them out of titanium. There are some implants that are ceramic. They're made out of the zirconia, same structure that we do a lot of our crowns with now. And there have been some successes with those as well, but we generally do titanium here. Okay. Anybody have any questions?
Which patient would it vary on how we would choose who gets what type of an implant?
Oh, the ceramic implants, I could go in depth on this, but some people think that ceramic implants are better because they're non-metal.
Oh, that's right, yeah.
But zirconia is still a metal.
Yeah.
It's just white when we make it.
Okay.
So it's a little bit different process to actually get to the zirconium oxide material than the titanium, but in essence they're both still metallic.
Okay.
But it is white, so sometimes in the front when people have real thin tissue and you don't want anything to show through, you may use a ceramic implant up there. We do our implants mostly all at the bone level. So what that means is we go back here. There's two different types of implants. There are bone level and tissue level. So bone level means that the top of the implant is at the level of the bone. So we don't often get a lot of show through of the gums because the implant itself, the titanium portion, is at the bone level instead of at the top of the gum level.
Right.
Does that make sense?
Yeah.
Yeah.
Just clarifying, so our lab, the Precision Lab, they can do the zirconia implants. They offer that as an option?
They'll do zirconia crowns, but not the implant body itself.
Okay.
Yeah.
So do we have a lab that can do that for us then?
There are companies that produce ceramic implants. I haven't actually placed a ceramic implant. It's
Okay.
just,
So we might, so more for, so I might have to reach out to like Glidewell or a huge national lab to do it.
yeah.
And the specialist can do the front teeth ceramic ones, right?
I believe so. Yeah, I think we've got
So I know
some.
sometimes you'll refer them to just get that.
Yeah, and sometimes the periodontist is a little bit better at managing the tissue. It kind of depends.
Yeah.
It depends on the comfort level of the doctor and everything there. So, the first step of the implant process obviously is to remove the tooth, right? We can't put an implant in where there is a tooth. That's not entirely true, but I won't get into that.
I was gonna say,
It is possible. It is possible, but we generally don't. We generally don't do that. So you remove the tooth. Now, sometimes the surgeon will want to really make sure that there's enough bone there when they go back in. There may be a number of reasons for that. One may be that there's not a lot of bone to begin with. Another may be that the individual feels like it's going to be quite a long time until they're able to get the implant. And over that period of time, the bone will actually shrink away. And so they would need a more extensive graft if we don't do a bone graft at the time we extract the tooth. Okay? So that for you that deal with the codes a little bit more, that is a 7953. Is that bone graft at the time of extraction. That's called ridge preservation. So because we're preserving the dental ridge. Okay. Any questions on that? In some cases, we may place the implant at the same time as the extraction. What reasons do you guys think there might be for that?
I didn't know we even did that, so that's something I just learned, so.
what'd you say?
Why do you think we might place the implant at the same time as we extract the tooth?
There's already a
Is
hole
it bone needs remodeling already? They're in a hurry?
Yeah, that's basically it. It's kind of time dependent. You know, patients may want to rush, or there may just be circumstances. For example, the other day, I did one conventional implant, but the patient also had a broken tooth on the other side. And so instead of doing two separate surgeries several months apart, we just did both surgeries at the same time and removed the tooth and placed an immediate implant on one side and a conventional implant on the other. So mostly it's just time frame. The immediate implants are a little less predictable. And so, because, you know, you have a hole now that you have to fill. And so if you do that, then you need a bone graft at the same time as the implant. So that's this D6104, is if you actually graft at the time of the implant placement. And then we're gonna let that heal for 3 to 4 months. So if it's just a graft, we're gonna let it heal for 3 or 4 months, and then we can place the implant in. If it's an immediate implant, we're gonna let it heal the same amount of time, and then we'll be still comfortable to go ahead and restore it. All right. So bone grafting materials that we have. Let's see if Chelsea brought anything for us. I think she got the bone grafting materials. That's okay. I've got pictures. So things that we'll generally use. We generally use we use these allograft granules. So there's different types of grafts. This is an allograft. There's autografts. There's xenografts. Here's what an allograft refers to.
Isn't that a donor body?
Yeah. So this is human bone. You can get bovine bone. You can get cow bone. You can get pig bone. So yeah, exactly. Yeah. For the people that didn't know that, that's what I was explaining. But Yeah, so this is what we use. We use human bone. This is taken from a donor, someone who has passed away and donated their body for science or whatever. So with the allograft granules, we'll place that, we'll deliver that into the socket with a bone syringe. There's several different types of these, but when you're looking in there, I think this is the new type we have. Looks like this. You guys have seen it, right? Yeah. So this is the bone syringe, and the bone will actually be packed in there and then delivered right into the socket. There are some bone putties. So this is like a mixture of allograft and like a kind of like a bone adhesive, and so that goes in. This is a little bit more costly, so we usually stick to the allograft granules and have good success. So when you're setting up for your bone graft, you'll want to hydrate these granules. Okay, so we have little sterile saline syringes that you can use instead of open a big bottle. So we've got that one figured out. And you'll just want those to hydrate before the graft is placed. Do you have any questions? Not at all. So there's actually a little trick I saw the other day that I think Dr. Pullen does. Usually when you get that saline in there, it's going to really fill everything up. But that's fine, you let everything hydrate. And then you just place a gauze over the top and suction off that excess. And then the graft material will be a little bit more easy to deliver. Because when you have it in the saline, it just kind of moves all around. So that's kind of nice. And it's hydrated, and it's kind of like a little putty almost.
Do we need to use a sterile gauze to do that?
Yeah. Okay, excellent. Any questions on bone grafting? Okay. So one thing about bone grafting to know is that it's really just a placeholder, and so the patient's own bone will remodel, and that graft will eventually be replaced by the patient's own bone, but it doesn't help with retention or anything like that. So it's just holding the space for us. After the bone graft is placed, we're going to want to protect it. Doctors are usually going to use a collagen plug or a collagen membrane. Okay. So the collagen, there's not much difference between them. They're both made from collagen. There may be different circumstances. Why do you guys think when do you think we might use a membrane instead of a plug?
When we don't have room.
Okay, good. We're running out of materials. Dr. Zeller.
When it's a big graft area, we have to hold in a very large area of bone.
Yeah, yep. If it's like a couple teeth or that we're deficient in an area, then we'll want to put that membrane over. We'll be able to suture that down and pack around that. So if it's a collagen plug, then the doctor is going to usually close it with a figure of 8 suture. That just keeps the plug in place, closes up the tissue, and helps that. We use Prolene here in the office. It's a non-resorbable suture. What does that mean for the patient? Yeah, exactly. So they've got to come back for us to remove those sutures. Something I've kind of learned with using Prolene is if you cut those sutures a little bit long, they'll actually lay down better, and that can be more comfortable for the patient. So yeah, if you cut them short, they just kind of stick up. They're like a little barbed wire. So patients don't love you when they come back after that. So we've done the graft. We're waiting for healing. We're gonna usually have the patient wait about 3 months, depending, 3 to 4 months for that graft to heal, or just for the extraction site to heal. Like I said, sometimes the doctor's not gonna wanna do a graft. There's plenty of bone. They're gonna get the implant really soon after the extraction. They're gonna just hit it right at that 3-month mark. Those are kind of reasons that we would go that route. So when the patient comes in now for a check for that implant site, what's that appointment gonna look like?
Probably do a scan, and a 3D scan,
Mm-hmm.
iTero scan, and a 3D scan.
Yeah, exactly. So we're gonna get a cone beam, CBCT, and that's gonna show us right where the bone is that we need to do. So the cool thing about cone beam, we're really lucky that we have that in our practice, because we can do the surgery digitally before we ever enter the patient's mouth again for the implant placement. So, so the doctor is going to use the software here, and we actually have the implant sizes and everything in the software that we can place it digitally exactly where we want it to go. Why do you think that is? Why do you think that's better than, or why do you think that is helpful? I guess.
So it's not crooked or going off the side of their.
Yeah, exactly. It's not crooked.
You know that it's the right fit, it's not too short, not too long.
Yep, exactly, because there's structures that we're trying to avoid, right? We're trying to avoid the inferoalveolar nerve that gives sensation in the lower jaw. When we're on the top, we're trying to avoid the sinus. We don't want to get outside of the bone anywhere, because that'll cause the implant to fail. What other reasons?
Do we need a bone graft?
Yeah, that would be another, are we gonna have to graft again, or are we gonna have to graft for the first time because we're deficient? Yeah, that's definitely a possibility.
Sometimes you don't have the other teeth to line it up, so you can't match it with the other teeth. Like if you're doing dentures, you
Yeah.
gotta figure out how to angle that carefully so that way everything will fit on to the denture later. So
Yeah.
you need to make sure it's straight.
Yep, exactly. So we can get all the angles correct so that when we put a restoration on it, whether it's a denture or a crown or whatever, it's gonna fit really nicely. And so that's the advantage to using surgical guides. So when we'll get the cone beam and the iTero scan together, and then we can send that off to a company called Anatomage, or our local labs can also make these. But we'll get a surgical guide back, and that will help, again, guide our surgery. So, assistance, what is helpful is after you've taken this, and one thing to make sure is that we've got a full arch scan, because there's the most stable surgical guide is going to fit on all the patient's remaining teeth if we're doing a tooth-bound case. And so a full cone beam, and then at least the arch that you're working with on the iTero. Okay, so you just need the single arch where the implant's going. Okay, and then once you've got that, if you can leave a note with the doctor, and then the doctor will give the implant size and everything to Liz to get ordered.
You want it open by Kobe?
Yes.
Patient needs to pay at this point for the implant?
Yes, we would ask them to to put $500 down so we can order the surgical guide and be prepared for the surgery. Yeah, otherwise we get a stockpile of surgical guides. That's not really true. We've got a couple in there, but of patients who have said they were going to do it, we ordered the implant guide, and then they never did the surgery. So that money down is just gonna motivate them to get the surgery done. And that's been going really well. I think it's almost been helping people get scheduled and getting their implants done. So now when we get to the actual surgery, the surgeon's gonna open up the area to access the bone. So one of the options, and so you guys can come and look at these afterward, out to you. But you can either use a tissue punch like this, or you can just open up a flap with the 15. So what's the difference? Why would we do one versus the other, do you think?
Easier healing and no sutures.
Yeah, the tissue punch is nice because we can just close it up without having to have any stitches or anything, and I'll show you. You'll see on the next slide for those of you who don't know what we would put there. Yeah, definitely. Why do you think we might do a flap instead?
For multiple teeth.
For multiple teeth, yeah.
Well, me, I'm gonna be very much a rookie. I'm gonna wanna see exactly where the bone is, so my implant stops right at the crest.
Yeah.
Right at the top of the bone.
Yeah,
I don't wanna go
absolutely.
too deep. and I don't wanna go too
Visualization
high.
is great. That you're gonna have be able to see a lot better where you are when you've got a flap open. What else? Okay, so a couple other reasons you might use a flap. One would be if you want to just cover the implant right back up underneath the gums. And we would do that sometimes for smokers, for people who have periodontal disease, or if there's maybe like a tissue deficiency. We don't want to take away too much tissue. Sometimes you might actually use the flap to move some of your tissue to a different location. So you want your implant crown to be surrounded by keratinized gum tissue. So this nice, tougher, lighter pink tissue. And so you may design your flap to actually push that to an area where you're deficient. And so then you may not cover up the implant, you may still put a healing cap on it. But yeah, so that's what you do. So once we've got that open, then we can get the surgical guide on, and we go through these handles. So these are the drill handles that we'll use. Some people call them keys. And so those insert into the surgical guide at different widths of our surgical burrs. So we'll open that up. What's that called when the doctor's opening up the bone? You know what the technical name for that is? Yeah, osteotomy. It's called an osteotomy. So these drills are kind of cool because what do they have on them? Assistants know. Swirl. Yeah, they've got depth markers, and then what do you notice here at the base of this, Cynthia?
Oh God, Dr. Altman, what I'm lying that bond edge. Right here,
Yeah.
that little like thick,
Mm-hmm.
yeah.
Yeah, there's just like there's a little ledge there. So that's just a stop. And so because we've done the surgery digitally already, we know exactly the depth that we need to go. So Anatomage is gonna design this surgical guide so that when we place an implant in it, then it's going to stop at the top of that. So you can see. So we know exactly the depth that our implant's going to go. So they'll go through this. They'll go through the series of handles. There are two different types of these handles. There's one with an R and one with a W. What do those stand for?
Or W width.
Wide. Yeah.
We
Yep.
have- What's the other? I know W is wide.
Yeah. W is wide. R is regular. Yeah. So there's regular and wide. And so just depending on the size of the implant and everything, you may use the regular or may use the wide. Those instructions are going to be on the paperwork that comes with the surgical guide. So it will list out here what implants you're using, what width they are, what length they are, the sleeve type. So this actually says regular on it. So you'll know to set up the regular handles, and then the drill depth. So we've got a couple of different depths. So we've got 26s. These are 21s. We have some 15s as well, in case your surgical guide, or your patient can't open wide enough, to fit your drills in. And then you can freehand it. So, that does happen occasionally. So that's one good thing to know. I probably could have assessed that before the surgery, but yeah, sometimes you just get in there and you have to do what you gotta do. So they're gonna drill in with those osteotomy burrs, and then that's gonna prepare. It's like you make a pilot hole, and then you're just gonna widen it up until there's room enough for the implant to fit. Why do you think you'd want to slowly open up that hole instead of just drilling the pilot hole the size that you want?
Because the jaw can probably crack. I mean, I know that with wood. Like, we know today.
I don't know that that's necessarily true, but that's a good thought.
Just because we wanna take, just like you have an X-ray right there, we wanna take a picture before we make it all the way big so we can adjust the angle if we have to. Right?
Yeah, absolutely. So that's definitely one reason is if our pilot hole is going to show us, we always take an X-ray after the pilot hole so that we know what our angulation is and is it on. I mean, with the surgical guides, it's almost always on, but there's always human error and everything, and so we could adjust that if we needed to. Any other reasons you can think of? The other reason is so that you don't burn the bone. So if you went in there with that big bore and it's got a lot of torque on it, it's just going to heat up. It's going to burn the bone and cause the bone to die, and the implant will fail. So once that osteotomy is open, then the surgeon's going to go ahead and place the implant in at a torque of 45 Newton centimeters. So you'll see that if you're in the surgery, you'll actually see them change the speed of the handpiece down to that 45 Newton centimeters. And then we're just going to take an X-ray to make sure we've got proper depth. Okay, this is the place where there can be lots of confusion. There's lots of parts and pieces to the dental implants, and there's lots of different dental implants out there. There's Straumann, Zimmer, Nobel Biocare, Implant Direct is what we use. Zest Anchors that make locators, they make an implant. So there's lots of different implants out there. We generally use the Implant Direct Legacy 3. It's got good research behind it. It's a Zimmer replica, basically, and we've had really good success with them. So we generally use the Legacy 3s. So for those of you who worked before I came, we would do a lot of original Legacy 3s, and it would come with all these things included, minus the healing abutment, actually. So you actually have the implant body itself. So when we talk about implants, this is what the doctor is always referring to, is this part here. A lot of patients are thinking it's just like the whole tooth. It's the part that they can see, right? That makes sense. But when we talk about implants, we're talking about this implant body itself. So with the original Legacy 3s, it will also come with this part. So what's this part for?
Is it for the impression?
Yeah, so it's for the impression. This has an impression coping on it. And so you would actually screw this into the, place this into the implant, and then you would take your impression. And then the impression coping is going to help the lab line up the implant on their model. Okay. So the Implant Direct, this is all one piece. So after the impression coping can actually be taken off, and this piece is the stock I'll go more into that on the next slide. But just know for now that this is a two-part piece. This is the screw that kind of holds these into the implant. And then these over here, these are for healing. So what's the difference between a healing abutment and a cover screw?
Is the healing abutment placed right after the implant is put in?
That is correct.
And then the cover screw, is that after the impression?
So the cover screw, the healing abutment, you're right, that's placed at the time of surgery. A cover screw also is, but in a different circumstance.
Like if they have a partial, you'll do the cover, and then healing equipment is a little bit taller.
Well, that is true. So the cover screw specifically is going to fit intimately with the top of the implant. And so the cover screw is used when we're actually going to just completely bury the implant. Why do you think we need a cover screw if we're going to just put it under the gums?
So much of gums don't grow.
Yeah, exactly. So the gums don't grow down inside the implant, so we put that cover screw. So the original Legacy 3, it came with this extender, so you could basically make the cover screw into a healing abutment. So if you weren't going to cover it, you could put this extender on and it would serve as the healing abutment.
I have a question.
Yeah.
So why would you choose to completely cover the implant?
That's a good question. A couple of reasons. One would be if you've got a smoker, that's going to be a little bit more, smoker, periodontal disease. Those are going to be instances where underneath the gums we're not going to have the exposure there.
Would you consider that too if it's not torquing very strongly? If it's like
Yeah,
high torque?
absolutely. Sometimes you'll get what in the technical term we call a spinner. So you get the implant in and you're torquing it to 45, and what you want when you're torquing it, right, you want it to eventually stop. And that means that there's actually 45 Newton centimeters of pressure from the implant to the bone. But if you put it in and it just keeps rotating, then you may want to cover it up completely so you know that there's no excess force on that implant while it heals. It'll still heal and it'll be solid as any other implant, but it just needs more time.
Does that happen if like your pilot hole is a little bit too big?
Could, yeah.
Cause you want the pilot hole to be smaller radius than the implant, right?
Right, slightly, yeah. So like on the maxilla, you may under prep because the bone is more porous there, and the implant will actually condense the bone a little bit. Sometimes on the mandible, you'll get in there and the bone is tougher, and there's that cortex, there's that outer layer of thicker, denser bone. Sometimes you have to actually open up that section a little bit more to get in there. So there's some burrs that we have for that. You'll see on the tops of these are listed that like at the top these say final for a 3.2 diameter implant. So that would mean that this is not 3.2 millimeters, but that it's the final drill for that implant. Okay, and then we've got these crestal bone drills here. So these are the crestal bone drills, and so if we've got that extra thick bone, the doctor will use one of these to open up the bone a little bit more so they can get that implant to depth. So those are some reasons that you might see where the doctor gets the implant in and then they back it back out. It's because it's not sinking deep enough. And then they may go back in with one of these other burrs. Okay. Any questions on the parts and pieces that I've got here? If you order a Simply Legacy 3, it's going to have just the implant, the healing abutment, and the cover screw. So that's what's in there with the Simply Legacies. Okay. Cool. Okay, then we get on to the abutment. So there's different types of abutments. So this is gonna, this will kind of give you some information on that. So after we've taken so the first type of healing abutment we have is, like, as far as sequence in the surgery. What do we have? What's the first abutment we're gonna put on? The healing abutment.
Or the fucking
Exactly. Yeah.
heavy one.
So the healing abutments first. So after the implant is healed, so again, we're going to generally wait about 3 months for that implant to heal. That's just the time frame that is the most predictable. I mean, we could wait longer, but that's the soonest time frame that's has the most predictable outcome. There are definitely surgeons that are, trying to push the envelope on that, and there's different techniques and ways that you can do that. But again, this is the safe route. So after we get after we have that healing, we're going to take an impression. So we're either going to use a scan body, or we're going to use impression coatings. So the scan body is going to be to use with the iTero. So we'll take off the healing abutment, we'll place the scan body into the implant, making sure that it's fully seated, and then we'll go ahead and make our scan around the scan body. And that gives the lab a digital image that they can work off of to make the implant crown. The impression copings are if we're going to take an analog impression with the PVS or the polyether, and they're formed like this because they actually want to gain retention in the into the implant, into the polyether or the polyvinyl siloxane. So that's what the difference between these are. Then we have a few options from there as far as what type of abutment we're going to use. We can have a stock or a prefab abutment. So for those of you who like to look at the codes, that's a 6056. So this is something that comes standard. We can order this. From the implant company directly. It's made to fit their implant. But what's the drawback of a stock or prefab abutment?
So sticking up the whole entire time?
It's kind of a one-size-fits-all type thing.
If the angle's a little off again, it doesn't correct it.
Yeah.
It will still be leaning a certain way, and it will make it hard to put the crown on top.
Yeah, exactly. So that's one thing. The other thing about a stock abutment is that it requires a cemented crown. Okay, and I'll get into a little bit of that on our next slide. So we can have a stock abutment, or we can have a custom abutment. So this portion here in the middle, it will connect to this, which is the same as this. It's called a tie base. Okay, so the tie base is what the lab is going to build up to form either a custom abutment or just a fully implant supported crown. The custom abutment is nice because it can correct for any problems in angulation, anything like that. A custom abutment is still going to require cementing of the crown. Okay, so this will come. You'll get it from the lab in two pieces: a crown that would look like your normal crown that we would see on a natural tooth, and then you would have your custom abutment here. That would be the tie base actually connected to this portion here. Okay? Is that clear? Does that make sense? And that's versus an implant supporting crown. Oh, take one more time. The other abutment that we commonly use is a locator abutment. What do we use the locator abutment for?
Dentures.
You know, man, just say the answer. Just say the answer. So yeah, so we're gonna attach that to dentures. And so that has a little housing that will go over the top of it and snap into the dentures and give us a lot better retention, than just your regular old pieces of plastic held in with spit. So, like I talked about, that implant crown is going to be created off of the either the scan or an impression. It's going to be screw retained or cement retained. So sometimes we can't get the implant to the angle that we want it to be. It's just not gonna go there. We have to put it in bone, and the bone's not gonna allow us to place it where we want to go. So sometimes we'll have a cemented crown for that reason. It's because we can screw the abutment in, we can correct for the error with a custom abutment, and then we'll go ahead and cement the crown on. So the disadvantage of cement, though, is that if we leave any of that cement around the margin of the implant, it can cause that implant to fail. And so I have tried to stay away from cement retained for that reason. And generally, with the surgical guides, we do pretty well because we can place that implant right where we want it to restore it for the most part. The cool thing about the software that we have is I can actually put a similar restoration digitally in 3D and decide where I want that implant to angle to actually come through in the proper place on the restoration. So that's really cool. So when we put how do we finish things up when we place the screw retained implant crown?
Teflon tape.
Yeah. So we're gonna pack the access with Teflon tape first. Why do you think we do that?
On the barrier.
Yeah, exactly. Because if we get in there and we mess up that fixation screw, then we're in trouble because we can't grab it and take it out. And so yeah, exactly. And then we go ahead and put composite on the top. I like to use the Dentin shades because they're more opaque, so they stand out less. Especially if a patient has like a mandibular molar, you won't be able to see that access at all if you use that more opaque shade. Any questions? Okay. So the last thing I just wanted to touch on is mini implants. What would you guys say is the main difference between mini implants and a conventional implant? One's smaller, one's bigger. Okay.
They're more cost effective, but they can possibly not last as long.
Yeah, that's kind of what we generally tell patients is that mini implants aren't designed to last a long time. That's not what their purpose was. Their purpose initially was to give extra retention while like a denture was healing with other implants placed in. So you'd load it onto the mini implants knowing that those were going to come out one day and then you were going to fixate that to some conventional implants. But we found that they can have really good success. The main difference in my mind between mini implants and conventional implants is that mini implants are restored on the day that they're placed. Okay? So like for these locators, we're going to place the denture onto the implant the day that we place the implant. And then I haven't done this much, but Dr. Keller I know has done a ton, is that you can put a crown on these mini implants. You actually cement it. There's just a hollow portion in the bottom of the crown, and you try that in, and then you cement it all in. And he's had mini implants that are in there that have been in there like 20 years. So, but they are a more cost-effective option. Partially because they're smaller, partially because they're not designed to necessarily last a long time. And then the other reason is that they come all with all the parts and pieces that you generally need to restore them, except for if you're doing the crown. So, another difference is that they're self-tapping. So you put a pilot hole in, and then you just put the screw right in.
Oh, the stretching,
Oh,
sorry.
you're just switching. Okay, sounds good. So that's mini implants, and that's kind of a broad, shallow depth overview of implants and how we kind of do them here. But does anyone have any questions? Any burning questions that you're like, this is something I just don't understand about implants? I want to know right now.
With the locator attachments, there's semi-precision and the other one.
Precision.
Which
Yeah.
one is for the, I always forget, which one's for the mini, which one's for the actual implant?
From what I've read in the codes, for the mini implants, well, I'll have to get back to you on that, because Dr. Keller and I think disagree on this,
Cause I know we have a cheater
on this
sheet.
point. Yes, we have that cheater sheet, but I think that if it's on an implant, it's a semi-precision attachment. If it's on a natural tooth, it's a precision attachment. There is a thought that maybe mini implants take the precision attachment code, but I don't think that's correct. I'll have to look I need to look in the coding companion.
I
Yes.
have a question. Yesterday I had a patient call about implants.
Uh-huh.
You guys use anesthetic during the whole process, right? Okay.
Yeah, well, I
can't
mean,
remember her question exactly.
yeah, we use it for the surgery, definitely. When we're taking pieces, like when we're taking abutments on and off, all that part after the surgery, then we're not necessarily going to use anesthetic during that.
Cause she was asking about like was it like a stent or I don't know what she was asking. But she wanted to know if you guys use anesthetic. I'm like, I'm pretty sure they do and the implant sounds painful.
Then she said a stent. She may have been talking about the surgical guide. Some people call it a
Oh, okay.
surgical stent.
Okay.
And that is, what she's asking is, do you guys do guided surgery? You know, which we do. Good question. Anything else? Okay, awesome. Thank you guys. I hope
Thank
that was
you.
helpful to you.